Ladies and gentlemen, please welcome Mohit Manrao of AstraZeneca and our esteemed panel.
Good morning, everyone. Thank you for being here. I'm Mohit Manrao, Senior Vice President for AstraZeneca Oncology, as well as President and Chair for the AstraZeneca Foundation. Today, we focus on an urgent public health need, repaying the debt we owe to women in cancer care. Cancer in all its form is devastating, but for women, the burden is often compounded by persistent gender bias and systemic inequalities that delay diagnosis and create barriers to quality treatment. These challenges impact women across the globe in all countries, with particularly devastating consequences for underserved patient populations, as well as for people living in low and middle income countries. Healthy women, though, are vital to our global economy and society and communities everywhere. They all are mothers, leaders, innovators, and caregivers. When we fail to provide equitable cancer care for women, we are undermining global access. Our mission at AstraZeneca is to push the boundaries of science, but innovation alone is not enough. We need to ensure these advancements reach patients who may be able to benefit. Today's discussion will highlight the crucial role all of us have in ensuring women get access to the care and treatment they need. Now, without further ado, I welcome our moderator for today's chat, Her Excellency Toyin Saraki, founder and president of the Wellbeing Foundation Africa, and a fierce advocate for women's and children's health and empowerment. Welcome and thank you for being here.
Thank you very much, Mohit. Good morning, everybody. It's a privilege to welcome you all to this important conversation on repaying the debt to women, advancing equity in cancer care. Across every region, women face systemic inequities that delay their diagnosis, limit their access to innovation, and compromise the quality of our care. These disparities are not incidental, they're structural, and they reverberate through our families, our communities, and our economies. Today, our dialogue is informed by evidence and by tools, such as the newly developed Breast Cancer Care Quality Index, published this month in eCancer Medical Science. This framework was co-created through a global cooperation and collaboration of oncology leaders, civil society advocates, and industry partners, with AstraZeneca serving as a convener and a catalyst in advancing its development. The index defines 10 global targets and 23 indicators across early detection, timely diagnosis, comprehensive management, and resilient health systems. As a member of AstraZeneca's Breast Cancer Care Council, I was honored to contribute to this dialogue that helped shape this work. It's an important step in translating existing guidance into practical, measurable actions that countries can adopt within their national cancer control plans. Therefore, our imperative is clear. Cancers that predominantly affect women, including breast, cervical, ovarian, and uterine cancers, together account for millions of new diagnoses and hundreds of thousands of deaths every year, with profound social and economic costs estimated in the trillions of international dollars. Breast cancer alone has become the most common cancer worldwide, with 2.3 million new cases and 700,000 deaths recorded in 2022. Yet only a handful of countries are on track to meet the WHO Global Breast Cancer Initiative target of reducing mortality by 2.5% annually. Without coordinated action, global projections warn of more than 3 million new breast cancer cases by 2040, alongside rising burdens from other women's cancers, which threaten to widen inequities unless urgent steps are taken. This is the unfinished agenda that we face together, and I'm delighted to be joined by two very distinguished leaders who bring policy, practice, and patient-centered experience to this urgent discussion. Her Excellency, Laura Chinchilla, former President of Costa Rica, whose leadership has demonstrated how national policies can transform equity, particularly in primary health. And Dr. Sheila Davis, the CEO of Partners in Health, who has dedicated her career to health justice and strengthening care in underserved communities around the world. Today we ask, what does it truly mean to repay the debt to women? And how can we translate frameworks like the BCCQI into action that delivers early diagnosis, equitable treatment, and survivorship with dignity? So I'd like to ask, the debt to women. We often speak of the debt owed to women in health. Could you each reflect on how gender bias and inequity manifests in cancer care and why this has persisted across both high and low income settings? Laura, over to you.
Thank you. Thank you very much. I want to also thank AstraZeneca and Concordia for highlighting these very pressing issues. The figures that you just gave confirms how important it is to have this discussion here and in every other forum. I would like to, in order to respond to your question, I would like to start with a kind of warning call and also commenting on two big structural challenges in advancing gender equity in health and specifically in cancer care. The warning call has to do with that, yes, we need to recognize that although progress on women's rights has been achieved during the last decades, especially on health issues, it is still limited. And during the last years, that progress is being, is losing track. So that means that we must do something else in order to continue with the same progress that we had some years ago. And concerning the two structural challenges I want to mention that are hindering women's access to healthcare in general and specifically in cancer, one has to do with the lack of access to healthcare services in many low and income countries, but also in rich nations we have vulnerable women who doesn't have enough resources as to pay for health care. So that is something that must be resolved. If women don't have access to health care, treatment of any kind, we cannot aspire to improve the figures on cancer care. So in advancing in this sense, my recommendation, according to my own experience in my country, is try to promote the kind of universal care access systems. So we can guarantee that everybody, every citizen, independently of their economic status, will have access to this kind of services. And as part of the universal access care system, the primary attention is still probably the key to try to prevent many of the illnesses. And the second challenge has to do with women's underrepresentation on the health sector. It is estimated that women make around 70% of the global workforce in health services, but they are holding only 25% of senior positions, and listen to this, 5% of leadership positions. When I was president, I decided to appoint two female physicians as the head of the main institutions, the Ministry of Health, and the main provider of health care services. And let me tell you, the situation started changing in terms of improving access of women to health services and also fighting against the problem of cancer.
Absolutely. That's wonderful to hear. And Dr. Davis, in your opinion, how would you define this debt to women?
No, I think at Partners in Health, we really believe that all people should have access to high quality care, high levels of survivorship, obviously, and all that comes down to providing care where people live. So we provide care in 6 countries in very rural areas. If women have to travel to receive care, they're not going to be able to do so. We know that they're the ones who are often the ones who are farming or the ones who are at the market, taking care of children. And so we have been dedicated to partnering with governments in rural areas and bringing high quality health care, a comprehensive model of which oncology is a piece of that. So we know if women show up with any issues, we don't believe that they should receive second-class care. So our goal is to do whatever it takes to try to make that possible. So we really invest in the 5 S's, which is staff, stuff, space, systems, and social support, and believe that single interventions don't work. You have to build the system. You have to be able to have high-quality specialists, nursing care, and that takes a lot of close partnerships with governments, with industry, with community groups. That's the only way we can make sure it's not a one-time effort.
You know, that takes me straight on to my next question, which is that the Breast Cancer Care Quality Index actually proposes concrete country-sensitive indicators, from ensuring that 60% of cancers are detected at stage 1, stage 2, when they still can be treated, to guaranteeing treatment completion for 80% of the patients. Which of these type of targets do you believe would be most transformative if governments actually adopted them? Madame Chinchilla.
Yes, of course. I will say that according at least to my experience when I was in government promoting kind of public policies, there were some measures that were very important. One is awareness, trying to launch awareness campaigns, telling the women what is this about and also how they can detect on an early stage when the problem starts. Secondly, diagnosis. And that is why the kind of primary attention is very important, because for many women, it is almost impossible to reach the big hospitals. So when you design those kind of mobile kind of teams, or you have small clinics all around the country, it is easier to also to bring the kind of diagnosis and early detection policies and programs. And finally, of course, treatment is going to be very important. But let me just close with this. When I was talking about underrepresentation, it is not only in the main positions, but also as part of the research. If we have the possibility to use innovation and technology through the more personalized kind of medicine, we need to make a segmentation of the research and information, so try to know a little bit more about the biology of women.
Yeah, I think our goal is to really make what is seemed impossible possible. So that's providing this high level of care. It's also why we've opened a university in Rwanda called the University of Global Health Equity in rural Rwanda, which is actually right across the valley from the Butaro Center of Excellence, the hospital where we provide our cancer care since 2012. And we're really committed to know that, we know that there's only 13 oncologists for the whole country of Rwanda, which has 13 million people. In New York, there's 2,000, and there's 8 million people. We know that the math doesn't add up, so we're really committed to ensuring that the next generation of those who are providing health care provide it in an equitable way, in a way that really centers where the care is, and also helping nationalist governments be able to follow their plan and ensure that we're looking at all the different aspects of care, which is very importantly includes supply chain, data, all of the structures that make this work possible. And if one piece of that puzzle is not there or intact, then women will suffer as they have for decades.
Thank you so much. You know, I was going to immediately ask you, so how did you bring policymakers to the table, not only to endorse frameworks like this BCCQI that we are now talking about, but to fund, legislate, and to actually integrate them into the national cancer control plans? What are the levers of political will that we will have to activate?
I would say that the leadership positions are still very important in doing that. When you have the political willing, everything else will work. You will have the resources in place, you will have the commitment of in the different levels of the bureaucracy and the different programs, but political willing is key.
I think for us, knowing that we have cases where we're provided excellent care and are able to bring those women as to show that it is feasible to provide care, I think policymakers like all of us are impacted by real human beings. So I think our role is to provide this care, study it, research it, document it, and be able to show and be able to bring that to say, this is critical that we provide this everywhere. It's not just because there's an NGO involved, it's truly the government's commitment, and we're there to help and be able to make sure it can be feasible, but it has to be a long-term commitment. It can't be 2 years, it has to be decades of commitment long.
So while breast cancer is our focus, the inequities actually do extend to uterine, ovarian, and cervical cancers. And you know, you've brought some lessons from the cancer care frameworks that can be scaled to strengthen the continuum of women's cancer care. If you were to recommend one action that governments, global institutions, and one action that civil society can take within the next 24 months to close the gaps for women with cancer, what would that one action be in each sector for each of you?
I will start mentioning this kind of national awareness campaigns and also teaching women how to early detect some of the first symptoms of cancer.
Thank you. And Dr. Davis?
I think, you know, ensuring there's accountability built into all of the systems, and again, educating women so they will go and be able to know what they deserve and what quality of care they deserve, what testing they should be having, and so that they can advocate for themselves and their sisters in their community. But we also have to follow that up with strong accountability measures.
Thank you very much, President Chinchilla and Dr. Davis, for your insightful contributions, and thank you to Concordia for convening this essential dialogue supported by AstraZeneca. What we've heard today confirms that inequities in women's cancers are not inevitable, but they are preventable. They persist because of structural gaps, but they can be dismantled through evidence, investment, accountability, and best practice. The Breast Cancer Care Quality Index provides governments and partners with a framework of measurable solutions, showing us how to move from aspiration to action across early detection, timely diagnosis, comprehensive management, and resilient health systems. The final ingredient, as we have seen, is political courage. Without leadership and sustained commitment, even the best of frameworks cannot deliver the change that women deserve. Repaying the debt to women means ensuring timely diagnosis, access to quality treatment, and survivorship with dignity for every woman, everywhere. Honored and privileged to have had this conversation with two women leaders, and thank you for your insight.
Thank you. Thank you.